So post-delivery, we'll see signs of a placental abruption. As we look at this picture, you can see the lobes on the left side. They are a little bit calcified, which means this was probably a baby that had some stress. But you look on the right side and you really just see blood clotting there. There's no real lobes, and that indicates that that had already pulled away from the uterus. So this would be a marginal abruption that's shown in the picture here, with probably some other port issues with those lobes. Let's look at the risk factors that we think lead to potentials for abruption. They include hypertension, multiparity, smoking, poor maternal nutrition, definitely cocaine use, chorioamnionitis or an infection in the chorion, overdistension of the uterus, so multiple gestation, polyhydramnios can lead to an abruption, and then of course blunt external trauma. So talking about this, the cocaine use is definitely something that can cause that, as can methamphetamines. When we look at blunt external trauma, things that concern us might be a car accident with or without that seatbelt on, but primarily if she is the driver and she hits the steering wheel, falls down the stairs, falls on the ice. Domestic violence, intimate partner domestic violence with that blunt force trauma to the abdomen could certainly cause an abruption. Our delivery options really depend on how severe the abruption may be or how the baby is responding. So sometimes if someone is close to the end, maybe they're 8 centimeters or they're in labor, we can attempt to continue on with a vaginal birth, especially if the mom and the baby are stable and labor is progressing adequately. Occasionally we'll have abruptions that cause a really rapid, intense labor, as if the body is trying to expel just because it knows something is wrong. And that can cause a really severe fetal distress. And so sometimes it just depends on how close they are. If they're already crowning, we may go ahead and birth the baby. But if they are moving very quickly and the baby's showing signs of distress, we will move back to a C-section. And a C-section is almost always performed if we know that bleeding is heavy, if there's fetal distress, or if the mom's vital signs especially are unstable. Another condition that is placental in nature is a placenta previa. And placenta previa is when there's an abnormal positioning of where that placenta has implanted at. So typically you'll see that placenta is up towards the fundus of the uterus, so up towards the top. And sometimes you'll see what we call a marginal placenta, and we'll look at this on the next slide here, where that placenta is placed on the edge or close to the edge of that cervical os. A partial placenta means that it is, partial placenta previa, it means that that placenta partially covers that cervical os. And a total previa would be the placenta occludes the cervical os. We may sometimes call a low-lying placenta when that placenta has migrated somewhere within a few centimeters of the cervical os, and sometimes as the pregnancy gets more mature, that placenta will rotate up a little bit, and sometimes it will rotate down into that marginal position. So you can see here in this photo that the normal placenta is up there at the fundus, the top of that uterus, and then there's a low implantation, and you can see where it shows that there's some bleeding, and that's because placenta previas can cause some bleeding. And then you'll see a partial placental previa where it starts to cover up that os. It's not right next to it, it's now starting to partially cover it. And then a total placenta previa in that fourth little baby's picture. You can see where that placenta implants at the bottom of the uterus and completely covers that os. So some of the things that we know are factors that can contribute to a placenta previa is, again, multiparity. Age greater than 35, so an advanced maternal age mom. Multiple pregnancies, previous uterine surgery, especially if they've had a C-section where there may be scar tissue that placenta adhered to. Being a smoker, having a previous placenta previa, that could also indicate that placenta may implant lower in the uterine wall a second time. And then any sort of previous elective or therapeutic abortion could cause some sort of scar tissue to form, and that could be a place of adhesion for that placenta as well. That would be in an abnormal location. So how do we suspect sometimes that someone has placenta previa? frequently they will present with painless bleeding. It could be scanty or it could be profuse. It could be a little bit of dark blood, or it could start to be really bright blood if it's active. They may have uterine contractions, and typically when they first start to bleed, it'll just be a little bit, and then each time that they have a bleeding episode, it will increase in volume. And if you can think about where that placenta is, that makes sense. The first time it's maybe just a little bit that's covering that os that starts to bleed, and then if they have a more substantial bleeding episode, you're going to have a lot more blood that comes from that placenta. Low-lying or marginal previas can sometimes deliver vaginally, but not very often. I mean, it really just depends on how much bleeding they've had during their pregnancy and whether that provider is comfortable enough in the facility that they're at. For instance, at Benefice, we may allow to have a low-lying placenta deliver vaginally or attempt a vaginal delivery, but in our outlying areas, doctors may not want to do that because they are several hours away from somewhere that can give them large transfusions if needed. Definitely when we have partial and total previas, we know when that baby comes down onto that cervical os that it is going to tear that placenta that is right there and cause more bleeding and threaten the life of mother and baby. And so those are always delivered via C-section. Things that we might do towards the end of these moms' pregnancies might be testing to ensure that that baby is still healthy. So if mom has a bleeding episode, for example, we might start to do what we call NSTs, or non-stress tests, where we'll just put her on the monitor at the office or at the hospital, and we'll be watching for contractions and for fetal heart rate to make sure that it still has good variability, that there are A cells, that the baby's responsive and looks okay. If we're at all concerned, so for example, if we do that NST and it doesn't give us a reassuring picture of that baby, maybe it has low variability, or maybe it even has a few D cells, or possibly it has no A cells, then we're going to probably order what we call biophysical profile. And those take about 30 minutes and are done by the ultrasound techs. The ultrasound techs then rate those babies, much like an APGAR score, on a score of 0 to 10. They look for breathing movements, they look for motion in the baby, they look for responsiveness and fetal heart rate, and they give you a score then that tells you how well oxygenated that baby likely is inside there. And then we also will have moms count physical movements by the baby, so they will put them on more strict kick counts. If someone has bleeding in the pregnancy and we know that they have a partial or a complete previa, if their bleeding has stopped, we may keep them on bed rest. If their bleeding continues, we may deliver them prematurely. But if it has stopped and that baby and mom both look stable, we oftentimes will try to keep mom's activity limited, possibly put her on bed rest until the lungs are mature, between 36 and 37 weeks. Or you may see that we're going to administer some antenatal steroids to mature that baby's lungs if we don't think that it is going to make it to full term. A major thing to be aware of, if a woman has a placenta previa, if we know that that placenta is somewhere near that cervical os, we as nurses are never supposed to do a vaginal check, so we should never be checking her cervix manually. And the reason for that is because, if you can imagine, you go in to do a vaginal check, and if that cervix is indeed dilated and effaced, and you keep going with your finger, you could actually cause more of an abruption of that placenta, because you would be then disrupting it and lifting it from the side of the uterine wall. So super important to educate moms that if they have a placenta previa, that if they go in for medical care anywhere, they should always inform the provider that they are not to have a vaginal check. That if we're checking for dilation, that should be done by ultrasound. Moving on to vasa previas, you don't see these probably quite as often as you see a placenta previa or even an abruption, but they do happen, and this is when that placenta doesn't adhere quite right, but it has like a gap in the middle, and that's when the fetal side of those blood vessels are actually, they run through the membranes that actually cover the cervical os. This is much more common to happen if the placenta is low-lying during that second trimester. Even if we think that it's resolved, we'll oftentimes do a follow-up ultrasound before we ever let them delivered, because they could have had some migration of fetal blood vessels over that os. Other risks are when that placenta is bilobed, or sexcenteriate placentas where it's the cord has come into a different area. We'll take a peek in a minute, and that will make a little bit more sense in a photo here that's coming up on why this is such a danger. So what you should know is that oftentimes we're having a lot more people come in without any prenatal care. And maybe because they've had drug use or something else going on, some psychosocial lack of access to health care, that type of thing. So occasionally we will do a vaginal exam on someone, and those vessels of the fetal side of that placenta are actually palpable on vaginal exam. You get your hands out, and you immediately are wanting to monitor that fetus for any detrimental effects of that. So again, even with vasa previas, if there are known vasa previa, we do not do a cervical check on them. That should be done only by ultrasound and providers that are aware of where everything is. But typically, if they do have vasa previa, they may present with some vaginal bleeding, or they may have vaginal bleeding with fetal blood, and typically they'll have more blood with the rupture of membranes. If you become a labor and delivery nurse, you'll learn a lot more about the sinusoidal pattern, but we typically with these babies will see a non-reassuring sinusoidal pattern, especially as that abrupts as well. These babies cannot be delivered vaginally and must be delivered via emergency C-section, or they will die. So you can see by these pictures here, this is what I'm talking about. So it can be a little hard to imagine without this. On the top left, you'll see where the placenta is kind of a low-lying placenta, and then you'll see those fetal blood vessels that then feed into that baby. You can see that those actually cover the os instead of the actual placenta itself. On the right side, you can see that picture of a placenta there, and you can see where all of those fetal vessels then go right to the cord. So that's what we're talking about. It's not the actual placenta that covers the os, it's these vessels then that cover the baby, or that get to the baby and bring nutrients and oxygen. If you can imagine, that's over the os. There's no way for that baby's head to go through. If it did, it would burst those vessels and would bleed out before it could actually be born. You'll notice in the bottom picture, the nurse is holding up that placenta. You can see the amnion there and how that fetal vessel comes out and is attached to that placenta. So that covers abruptions and placenta previa. Join me in the next part for uterine rupture.